Good morning. This is a parasternal long axis view of the heart. So you can see the left atrium here, the descending aorta behind the left atrium. You've got the mitral valve opening here. This is the left ventricle. You've got the aortic valve here and the aortic root coming out here. So what I'm going to do is just run through some of the sort of more basic measurements that we do for an echocardiogram. The wave that comes across is the lung, so you sometimes get a bit of dropout. So I'm just going to use M mode through the base of the left ventricle. You just go to the tips of the mitral valve and you can just see quite nicely the left ventricle cavity changing in systole and diastole. So I'll just freeze the image there. So what we can do here is measure the chamber and the septal thickness and the posterior wall thickness. So we'd normally have the patient connected up to an ECG and use the ECG to guide you to end diastole and end systole, but we'll just approximate it. So we measure the intraventricular septum here. This is the cavity of the left ventricle, and then we measure the posterior wall in diastole, and then we come and measure it in systole, and we can then go and measure how much that septum thickens up, and we can measure the posterior wall. So from this we can see we have a fractional shortening of about 44% and an ejection fraction of 75%. So that's nice and normal. This is really looking at sort of systolic function in the radial axis. So it has its limitations. In pregnancy, the septum and the posterior wall thicken up, so you get some mild eccentric hypertrophy during a normal pregnancy. So the other thing we look at in this view is, I'm just going to zoom in on the left ventricular outflow tract. We use that for to calculate the stroke volume to derive your cardiac output. So we'll just zoom up on the aortic valve. You can see this is the right coronary cusp and the non-coronary cusp. So I'll just freeze the image here. And where we want to measure the outflow tract. So this is the leaflets of the valve, and so you just want to see where the valve leaflet comes in, and we measure across, and that's our diameter for our left ventricular outflow tract, and that's used in your calculation of the cross-sectional area, so you can get your stroke volume. So I'll do the second part of the measurement when we change views. You can put some colour. I might just put some colour on and we'll just optimise that a bit, Julie. I can get that, yeah, get the box a bit smaller. So you can just see the flow through the outflow tract and have a look across the mitral valve. You get a bit of trace regurg that we're not that bothered about, and you can look at the septum across here with colour as well. So I'm just going to change to the apical four-chamber view. Watch out. Sometimes you find yourself hanging off your patient's ribs, so it can be a bit uncomfortable for them. And in pregnant women, their breasts get quite sensitive, so we just have to be quite careful. So what you can see here, this is the left side of the heart. This is the left atrium, right atrium, left ventricle, mitral valve. So what we're going to do is put some colour on and have a look at the mitral inflow. just want to bring the scale down a bit. There we go. And you Doppler at the tips of the mitral valve. Just bring our sample volume down a bit. We might need this. Let's have a look. So what we can, I'll just freeze that here. What you can see, this is the mitral inflow. So this is called the E wave, and this is in early diastole, and then the A wave in late diastole. So in pregnant women, the A wave gets taller, and you get a reduction in your EA ratio. So you do get a change in your diastolic function in pregnancy. I'm just going to go look at the I'm angling up to get an apical 5-chamber view so we can have a look through the outflow tract. So you can see the aortic valve flicking away in here. So if you put the colour on, can we get a bit better colour filling? There we go, that's better. And if we place our sample volume, now you want it to measure your stroke volume for your cardiac output. You need to make sure where you've measured your outflow tract is where you're sampling. So we need to be at the annulus of the valve. So you can see this is the blood flowing out through the ascending aorta and systole. So what we can do here is measure this column of blood. No, that's right. And this is the velocity time integral. So we just trace around it. And from using the velocity time integral and your cross-sectional area of your left outflow tract, you can see here we've calculated a stroke volume. So to get the cardiac output, we can then measure your heart rate. So we just measure it over a number of cycles, and you can see that the heart rate's 67, so it will then be able to work out the cardiac output. So another way of working out stroke volumes is using a Simpsons. We zoom up on the left ventricle, and basically we're measuring the volume of blood in the cavity at end diastole and end systole. So don't worry about that one. You can, okay. So I'll just freeze it there. We would normally have the patient connected to an ECG and use the trace to get end diastole and end systole exactly, but we'll just use the eyeball it. So you measure the area. Sticky mouse. Okay, and then you measure the chamber's empty. And we get a stroke volume, cardiac output, and we would normally do, I'll just demonstrate from the 4-chamber, but to get a more accurate measurement, you repeat this in the 2-chamber view. But this view is actually nice. We do the measurement, but you actually spend your time looking at the chamber and having a look, assessing the wall motion and the septum, and making sure that it's all moving in time. And she's got a good squeeze. So what I'm going to do now is I've shown you some systolic function and the mitral inflow, which we can infer some information about diastolic function. But the mitral inflow measurements are dependent on preload, so obviously that changed dramatically in the woman. So
could you just explain to the less initiated what this artifact from left to right is? Is that the rib that you're trying to get across, or yes?
Yeah, it's in the depth that you can't see. So you're hanging off. It's in the third dimension, so it's hanging off the rib, and you get that displayed across.
So it's you just have to think of it and look by it.
That's
right. That's what you do.
It's poor Sarah here. I'm sort of angling right off the edge, so it's just ribs and lungs you've got to get around. So we use tissue Doppler, and that's a better measure of diastolic function because it's primarily independent of loading conditions. So we'll just zoom up on there and we'll put our colour on. And as you can see, the colour is tracking the tissue and not the movement of blood. So I'll just open up my sample gate here. And so basically you've got the mitral valve annulus and you're having a look at the movement. So when the heart contracts, you've got to think that the apex of the heart remains still and it's the base that twists and descends down towards the apex. So there's a twisting movement towards from the base to the apex. So if we just... So what you can see here is this is that pattern of the E wave, so in early diastole, the A wave in late diastole, and this is the systolic wave. So this is towards the baseline, so and this is away as you have filling. So this is a normal EAS pattern. So when you start to get diastolic function, this is where you start to get your changes in your EA waveforms, and that's more sensitive than the mitral inflow. So we do it at the septum, and then you come across to the lateral wall. And we can again see that pattern of the E, A and the S. And that's a nice normal trace. Do you have any questions, or do you want me to show anything?
If has any one of you got a question, please move up to the microphone and put it. No? Word? Well, I think everybody's been quite impressed, and I think we thank you very much for this.
I do have a question, actually. Could you just do this tracking of the volume of the ventricle again?
The Simpsons calculation. Yeah. So basically, it's quite simple. It uses the summation of discs, so you'll see, just get a bit better. We all sort of feel it's a rough sort of estimate. We don't kind of routinely, you do it from an eyeball perspective and to get a figure more so than to use it more scientifically.
Okay, now
yeah?
how reproducible is this?
Well, it has error. That's why we don't use it. It's very dependent on the operator and things. So it's a good general measurement, but it does. It's reproducible to an extent, but we tend to, when you're doing echoes, you tend to look at the heart, and by just looking at it, you can tell what you expect the ejection fraction is. We don't use this for stroke volumes and cardiac output.
And who should do this examination? Should it be obstetricians or cardiologists or internal medicine specialists, sonographers?
Well, I think as long as you have the right training, I don't have a problem with people's scope of practice crossing into other areas, but it depends what you're using it for. I mean, if you're trying to look at hemodynamic function and you want to do, you know, so you have your mean arterial pressure and you want your cardiac output, but it's like with anything, you need to know what you're looking at, so when you come across other things, you know what that means. So you need to have a you know, reasonable in-depth knowledge of cardiac function, and you know, you do these measurements, but you get all sorts of variations, and being able to interpret that is important. So you know, I think if you work in a team, that's probably your ideal situation.
Well, thank you very much. If there are no more questions, then we can wind up this part of the. Did you see a question? No. This part of this morning sessions, and we thank you very much, Kate, and your
Pleasure.
And your model also for her patience. And we move on straight. Yeah.